Perspectives and lived experiences as a patient are exactly the type of focus we endeavor to develop and create space for in medical education and community outreach. As the director of the Narrative Medicine program, I want to nurture value for patient stories and preferences in our next generation of students and healers. I also see the University of Arizona College of Medicine Phoenix as a research leader in bringing new therapies to light to cure diabetes for people affected around the world.
As we round out the exhibition, we're asked, what's your story?
Good evening and welcome. Can everyone hear? Are we good? I think. Just want to check that we're live on our mic. Great. Well, welcome to those of you that have joined us in person and those of you online. Thank you for joining us this evening. I'm Michael Lee Zirulnik, your host for this evening's event. I also have the privilege to serve on the faculty here at the University of Arizona's College of Medicine, Phoenix, in the Department of Bioethics and Medical Humanism. I'm also obviously the artist behind the virtual tour we just went on of Strips and Needles, A Day in the Life, for which this final public programming event is framed around. Joining me and moderating the online chat is my colleague and co-author of the exhibit, or co-curator of the exhibit, Dr. Jennifer Hartmark-Hill, celebrated physician, associate professor and director of narrative medicine, among a host of other notable titles here at the University of Arizona's College of Medicine, Phoenix. Welcome, Dr. Hartmark-Hill. Good to see you.
Thank you. Good to be here.
As we get going, we invite you to contribute to the exhibition and share your story of hidden disability or your reflections on the exhibit. For those here in person, you're welcome to post directly to the storyboard in the lobby. For those of you joining us virtually, you can send your 1 to 3 sentence story directly to Dr. Hartmark-Hill via the virtual chat feature or email us. And we can put my email in the chat as well, zirulnik@email.arizona.edu. I think that's right. And by the end of the week, any of those beamed in stories will post for you to the wall in the lobby, and it'll become a part of the exhibit. Today's event focuses on research findings that can be implemented with immediacy to prevent illness, improve health, and drive funding to support these means. We'll be in conversation with Ms. Julie Hoffman here in the center, Dr. Dorothy Sears right next to me, and Dr. Gabe Shaibi at the far end of the table. It's sure to be an informative, personally insightful hour with an opportunity to ask questions and to contribute. Dr. Dorothy Sears is professor of nutrition at the Arizona State University College of Health Solutions and has been conducting cardiometabolic disease and cancer research since 1995. She aims to identify and characterize novel health promoting behaviors. Her most active research is focused on improving health outcomes through circadian alignment of food intake and breaking up prolonged sitting time. I've had the pleasure to chat with Dr. Sears one-on-one about it, and it's fascinating. I could have listened for hours and have already started implementing some of what she shared with me in my life. So thank you for that gift. Ms. Julie Hoffman next is the chair of Advocacy for the American Diabetes Association and serves on the leadership council of the Arizona Diabetes Coalition. As a trusted health policy advisor, she focuses on building patient-centered consensus among legislative, industry, academic, and community partners, no small feat whatsoever. And her daughter, Taylor, who I've had the pleasure to meet, has had type 1 diabetes since she was 1.5 years old. And really great work that Ms. Hoffman is doing, and I'm so glad she joined us on this panel today. And last but certainly not least, the far end of the table here is Dr. Gabriel Shaibi, professor and Southwest Borderlands scholar at Arizona State University, where his research focuses on understanding and preventing obesity-related health disparities among children, families, and communities. His work spans the translational spectrum and includes collaborations with teams of researchers, clinicians, and community partners to improve health among vulnerable and underserved populations. Dr. Shaibi is a grant recipient of many grants, including his most recent, I think it's your most recent, a $10 million National Institutes of Health grant that focuses on what I just shared. And I hope that he'll speak to that this evening as well. So thank you to our distinguished panel for joining us this evening. And with that, let's go ahead and begin our conversation. I'll start with a series of questions that I'll ask each of our panelists, and then we'll invite you to partake, participate, ask your questions, or share your stories. Great. So Dr. Sears, I'll start with you. Why do you do this work?
Ever since I was in college, I knew I loved biology and science, and I wanted to help people. I wanted to help people who are at risk for disease and have particular diseases of concern. I guess all diseases are of concern. So I started out as a molecular biologist where I got my primary training, but I really was not as gratified with the work, just working with molecules and working at a cellular level. So luckily for me, I was working alongside physicians who were endocrinologists. So side by side at the bench, I started talking to them about the realities of patient care and what is type 2 diabetes all about. And I was doing work related to that, but not the clinical subject. And the more I learned about, there's just so many things that we can do to prevent cardiometabolic disease and to alleviate complications that folks who are living with these diseases, we can just, and it's so powerful, so as powerful as the drug. So I, over some time, shifted my work to work with people. Why do?
Thank you. And I just got a quick text message that we need to speak. Sorry about that.
So I will go next. Well, initially I started doing what I do now because I had to. My daughter was diagnosed with type 1 diabetes at 18 months old. And the short answer is now I do it because I'm compelled to and I'm honored to. So it really is a privilege to still be an advocate for not just her, but for everyone with diabetes. When she was diagnosed 6 months before, the only person that I knew with type 1 diabetes, I was with just hours before she passed away in her sleep from hypoglycemia. She was a 21-year-old scholar athlete at University of Arizona in Tucson on the softball team. And it was shocking to get the call that she had passed away, having been with her less than 12 hours before. And so as a younger person hearing that and really realizing how vulnerable someone with diabetes is, 6 months later, my daughter's diagnosed, and it frightened me beyond measure. That compelled me to become an advocate immediately, and I realized the barriers that people have. I was denied a job transfer. In her first 6 months of diagnosis, I was denied a job transfer because of her diabetes. I was also adopted, so I could not answer any questions that they asked me about my medical history or family background. She was non-medical switched insulins and test strips twice within 6 months of diagnosis. And so without having access to the thing, forgot childcare. We could not get childcare for this little toddler with type 1 diabetes. So that trajectory, fast forward almost 25 years, and I'm still advocating for her and everyone else now, type 1, type 2, it doesn't matter. We're all in this together.
Zoom, same question for me. How am I supposed to follow that? Do this work because they pay me to do it. No. Like you said, there's reasons that have changed over time why I do this work. The work that we're doing now, I do it because it has what we call impact, and we measure impact in a bunch of different ways. It advances the science, which as a scientist I think is important, but equally important is it changes the community and it impacts the community. And I think the work that we are honored to be able to do with our community partners, many of whom are here, really does have meaning. And the two other reasons we do this are because we train the next generation to think about diabetes and diabetes prevention in a way that is different than the people who trained us. And so we're advancing what diabetes and diabetes prevention will be like in the next 10 to 15 to 30 years. And lastly, we do it because it's really fun. We get to work with good people and ultimately making an impact by seeing other people grow, seeing the impact that we have on our participants, and seeing the impact of those changes have in the community at large. And so it really is fun.
Dr. Shaibi, you mentioned impact, so I'll stay with you for my next question. What are the advances in diabetes care and prevention that you've made in your research, and then Ms. Hoffman in your advocacy, and Dr. Sears in your work?
Yeah, it's a tough question. It's actually the same question my mom asked me during my PhD defense. It's, what have you done with all of this? That's a good mom question. And how do you respond to your mom during your thesis defense? Mom. So I think the advances that our team, and I don't, kind of say me, but our team has done, is we've brought evidence-based prevention programming to the forefront of community-based programming. And what that means is we're bringing the best available science to the communities who are able to actually implement that science. And we don't generate science in the lab and then have community members figure it out. We generate that science with our community partners in real time. And so if something works, they don't have to wait for a publication to be peer reviewed to actually turn that into impact. When it works, they automatically change their practice and they can do that in absolutely real time. And so it's a different mode of doing work with community partners as opposed to in communities or for communities. We do that with communities. And so I think that we're generating real-time science that has real-time implications in the community.
Well, one of the first things that I did following Taylor's diagnosis was contact my legislators, contact ADA, and see what I could do. And in 1998, and it's hard to believe, I mean, it wasn't really that long ago, but that was the first time that we had to put into statute that insurance companies had to cover simple management tools like test strips, syringes, insulin, glucagon. Those very basic diabetes management tools did not have to be covered by insurance companies. Granted, they were much more, I dare say the word, affordable. The cost was not as high. Things like that have been unaffordable for a segment of the population for a long time, but certainly much more affordable than they are now. And I've seen one vial of her insulin go from $23 when she was first diagnosed to over $300 now. So that 20-some year spread of advocating for more affordable access to care, whether that's treatment, pharmaceutical benefits, now devices. We've seen a transformation in diabetes management where many people with type 2 are now prescribed the same devices, the same insulins, and many of the same treatment modalities as people with type 1. And we really hadn't seen that much before, but now with continuous glucose monitors, affectionately called CGMs, getting coverage for those, much more wider coverage is available. Medicare now covers those, which means commercial payers follow. We are in process now of working with Access to get more significant coverage of CGMs for people with diabetes. And in advocacy, we still have to realize that the payer has a perspective. And so over the years, we've had to find that middle ground to where providers and physicians in this room work with patients, advocates, patient advocacy organizations, and other community partners with the payers to find exactly what patients need and get that covered, because we all know that long-term, it's better to get in on the prevention side and stop comorbidities. And that is, we all preach that up here, but actually putting that into action feels like a very slow speed run sometimes. And it's, we couldn't do it without all of my great partners in the room. So thank you.
So for impact, I think one thing that happened, I would say about 12 years ago, was my merging my molecular approach to things with behavior change folks and working in teams where I am able to impact their work and they on my work by just bringing my expertise to the team and trying to determine, for example, we know that reducing prolonged sitting time, well, we speculate that. We know that increasing exercise is good for health, but we don't really know exactly why that is. And so you have to look at the molecules in the body and the tissues to look at that. So the combination of the behavior teams and their expertise and my molecular expertise, I think, has been really exciting for me and I hope impactful. And that has led to my thinking in a very translational way, as we say. So we want to be able to translate the science to the community, like what Gabe was just mentioning. So for example, when I started doing research on the negative effects of prolonged sitting time, we know that prolonged sitting time is detrimental to health, but we have no idea why it is. And we have some ideas, but we don't know what to make. We don't know what public health recommendations to make about it because we don't know how long is too long. And if you're not sitting, what should you be doing? Should you be doing jumping jacks, climbing the stairs, or can you just stand there? And so my latest research funded by NIH and the American Heart Association is to investigate these parameters. How long is too long? What do we do when we're not sitting? And then what's happening in our bodies that will lead to cardiovascular benefit, reduced risk of diabetes or diabetes complications. So I'm really excited about that work. I actually just want to say one other thing, and that is that a lot of times in science, we want to intervene in a way that we think is going to work, where the biology, we're going to affect the biology. But the problem is sometimes the way we would design that is not practical at all in anybody's real world. So for example, some of the initial studies in reducing sitting time had people get up out of the chair and walk on a treadmill. Well, I can't fit a treadmill in my office, nor can I really afford to have one there. And if my mom got on one at age 86, she'd probably kill herself the first day. So coming back to that translational science, you have to think about how is what I'm doing going to apply to the real world. And I should be really testing methods that people can actually do.
From your perspective, can you, either yourself, Dr. Sears, or Dr. Shaibi, explain to us what translational research means in terms of a public audience and how it's defined in your fields, in your praxis, and perhaps by the NIH? What does that look like?
So maybe I'll start with the mouse model translational work. So I did a little bit of mouse model work. It's thinking about what are we testing in the mice that we can do in humans practically. And being fully aware that what happens in a mouse is not guaranteed to happen in a human. So the understanding in the mouse community, the mouse research community, to be translational is that you have to be aware of these things and then to really be partnering, in my opinion, with clinicians, with behavior change individuals, with a clinical population, so that you can check in and is this going to work in the humans? No, we got to tweak it a little bit, go back to your mouse and back and forth. So having a really dynamic exchange of experiences and knowledge between groups of these different levels of scientists. Yeah, and then I think also just being able to translate what I do to a community setting. So if I can take my clinical laboratory research on sitting time and then make effective recommendations to people who work in an office setting and sit all day, or truck drivers, even for example, sitting all day, how can I apply? So I'm translating what I'm doing to the real world.
Yeah, I think for a long time it was the lab bench to the bedside. So you have a discovery, you find a mechanism, you take that discovery or that mechanism, and you create a new a therapeutic target, and then you have a new drug for that. So that was what the original translational research was: is bench to bedside. I think to Dr. Sears' point, it's actually expanded now to multiple levels of translation where you're not, talking about just in the clinic, but into the real world. And so we think about from lab bench to park bench, and then from park bench to public policy. So how do you get the work that needs to be done in the way it needs to be done to those who need it most, and then learn from what you've done? And that actually goes both ways. It goes, people often think of it going, translation being one way, from the bench all the way to public policy. But what about those policies actually can come back and influence biology, and understanding that translation actually goes both ways. So maybe that's how I would define translation, is kind of understanding at the molecular basic science level all the way to translating that into public policies.
I love that phrase, from lab bench to park bench. It makes a lot of sense.
Not my phrase.
I'd like to add one thing to that. I know that Dr. Shaibi and I had an aha moment together a handful of years back when he realized, in talking to me about advocacy and diabetes, that translational research being put into public policy language, that is where he thought, and it was a misunderstanding, but that's what he was told in academia, that's hands off. This is where your road stops. You do the research, you publish, and then you just organically let the public policy gnomes go about their business and make change happen. And that is absolutely, I will dare say, scientific malpractice. It really is, because without approaching policy at the next level, that does not, by doing that, you're educating people. That does not make you a lobbyist, which obviously would be a conflict of interest, but you are still an educator. So ultimately, I'll never forget seeing him just go, wow, I never realized that. And it really has changed our work together over the last handful, 4 or 5 years, and the way he approaches everything with his team, his research. And so I'm excited about more people realizing that their scientific research is at the absolute basis of policy, and it's local too. So the things that he understands, that's the best, he's the best translator to, let's say, legislators here and other public policy people.
Yeah, thank you for sharing that. And in large part, why this panel had come together is, one, using arts and humanities as a conduit to bring together disparate groups, people, and populations to talk about things that matter and impact all of us. 1 out of 4 individuals in this country is impacted by a hidden or visible disability. So we're all at some level impacted by this. And I think the beautiful thing is, here we have individuals from the University of Arizona and Arizona State University, and working in public policy and advocacy, and Creighton University, all coming together in this space to work on really similar issues in a collaborative way. Whereas that competition, yes, it may still exist in certain areas, especially when competing for grants, et cetera. But what we know is, when we come together, our impact and our outcomes are far more dramatic, significant, and meaningful to the people it matters to, which is the public, who really are the people that employ us. And that's what makes me happy to have this panel together here today, and the support of all of our leadership to say, yeah, it's okay, go for it, do it, and not have to worry about leaving this panel and having a dean call one of us. Because that may have been another decade ago, but it's not today. Although after this panel, I may tell you differently. Well, with that, what lessons, because we're talking about translational and we're talking about impact and the public, what are the lessons that you've learned over the years or that you're learning now that can be applied to other public health and disability issues, for instance, mental health or some other visible or hidden disability that you've learned that won't just impact the diabetes community, but the community writ large?
I can jump on that. Because it kind of piggybacks on exactly what you just said, is the importance of cross-sector collaboration. And, these are such complex problems and have so many moving parts that if you don't bring in the right people at the right time, you're not going to find the right solutions. And that timing changes. And so ultimately, what we're trying to do in our group, and our group does cross a lot of different institutions, but it also crosses sectors, and sectors who don't usually work together. And so when you think about the healthcare sector, it's all about reimbursement. And then you think about the community sector, it might be about donations. And then when you think about the public policy and advocacy sector, it might be about relationships. And so we have to kind of figure out how to bring these sectors together, and that bringing together of people across different disciplines is important, but so is across different sectors, figuring out mechanisms for making that relationship mutually beneficial. And it is very different, right? So sometimes it's reimbursement, and other times it's, hey, we just want to be at that table because we have something to say. We can use being at that table to fulfill our mission.
Does anybody else want to jump in on that?
Yeah, I would say, I think you were speaking to this, but scientists, I think, traditionally don't talk to what we call the stakeholders. So who are the public that we are trying to serve? Who are the clinicians that are taking care of those affected by disease? We have to be talking to them to understand what they want, what do they need. I mean, we have a lot of science and literature we can look up, but that really is so aggregated, you can't get to the granularity of what really is needed. And so I think really being in touch with people and organizations that are involved at all levels is so key, so that we do even the most basic science in the right direction. If I learn that a mouse can eat his body weight of carrots every day and never get cancer, that is not practical. It may work, but nobody's going to eat their body weight in carrots every day just so they don't get cancer. So it's so critical that we are really trying to see from everyone's eyes how they view the problem to really come up with the most feasible solution.
And I would add that, especially from a clinician's point of view, and then in the advocacy, public policy work, because it is all collaborative in nature and it's all patient-centered, right, is to put on that emotional intelligence and extend empathy from the beginning, to approach things with an understanding that you probably are not the person that all of these things are happening to. So you really have to put yourself in someone else's shoes. And I would suggest to talking to somebody, finding somebody, and all of us are very approachable. And this is another good friend of mine in the audience, Daniel Rodriguez Guzman, who is the diabetes program manager for the Arizona State Department of Health. And I've worked with him for a number of years in the diabetes community. And he has a passion for prevention, and certainly that emotional intelligence that anyone here, you can talk to him afterwards too, that he'd be happy to speak to you. But I would also encourage everyone to find a partner in not just the diabetes community. But other chronic diseases, and like Dr. Z said, they often are invisible. And many times the comorbidities that the patient is experiencing they're also invisible. In diabetes, especially type 1, as you guys know, it's an autoimmune disease. So many people with type 1 have other autoimmune diseases, and these are often very expensive, very physically draining diseases, and no one knows because the patient is that resilient. But that word resiliency that we hear all the time now in disease management brings me to my last point on this question, and that is what you said, the mental health aspect. I will make a pitch right now to the University of Arizona College of Medicine, Phoenix. I appreciate so much your focus on primary care at this institution. We have for many years fought to get the scholarships for primary care. We know that there is a physician deficit that will continue to experience for many years. But the mental health of people with chronic disease has gone widely unaddressed. There are not many, I could count them on one hand, providers in this area that work with the public. And when you consider how many tens of thousands of people have diabetes in Arizona, hundreds of thousands with pre-diabetes, people with chronic disease end up all dressed up, no place to go. And so all of that emotional angst often stays at the workplace. It stays within the family unit, and there's no outlet. There might be a support group online, some Facebook group, but the traditional support group of Tuesday through Thursday from 5 to 6 in the hospital cafeteria, that's not practical for most people. So I really put out a call to action to the university to work with all of us and we promise we'll work with you, but we'd like to open a dialogue and some kind of fellowship in chronic disease, mental health, collaborative programming. I don't know what we want to call it, but I know that we need help. Yeah, we need help with the name. Thank you, Gabe.
Ms. Hoffman, I will give a shameless plug for the next installation I've got coming out, which is a partnership, which is another longitudinal assessment and study that captures the life of an individual suffering with depression. And it will be another visual representation of what that looks like, that we can, again, bring people together, continue to address the taboos of mental health, and do the type of work that you're pitching. And I hope the dean heard you or does hear you tomorrow, and perhaps we'll give you a call.
I think this is part of mental health, but I would say depression is also quite unrecognized, especially among those with chronic disabilities, dealing with diseases on a day-to-day basis. It's a huge struggle. As I think Dr. Zirulnik's exhibition outside is just a small tip of the iceberg, but it's a huge burden. And so depression, I think, is quite common amongst folks across many different disease types, poor quality of life, economic stress. I mean, there's a lot of linkages there that we don't learn about in biology class.
As we consider our own individual lives, virtually and here in the room, what's the one takeaway that you want to leave us with here that may empower us as individuals in the public at large?
Empowerment. Think about empowering. How can you empower yourself to take the lead on your own health outcomes? And I don't mean to do that in isolation, but think about empowering your patients, your neighbors, your family, your colleagues. We have a lot of power over our health, and unfortunately, that's undersold. We live as a kind of treat the disease, not in the prevention mode. And with nutrition and physical activity and reducing your sitting time and not eating at night, there's just so many things that we can do to empower ourselves. And I think when people feel empowered, they do better in dealing with the diseases that they're living with or that they are at risk for. And certainly in the diabetes community, a lot of folks feel like, well, diabetes is in my family, there's nothing I can do about it. And so then they don't. So we really need to do better, all of us, in communicating this ways that people can feel empowered and do something for themselves.
I would suggest to everyone here at the university to find a policy group. If you're a student, I know that ARMA has a student policy group they have representatives from all of the medical schools there. I do think that this campus, and I don't know if they still do, but several years ago, I know that they had a policy group amongst medical students. There are legislative champions for graduate medical education, and I know many of them, and I would love to have somebody come join me at the Capitol one day, and we can just sit in a health committee together. You don't have to wait for the U of A day at the Capitol. So once session starts in January. So really, it's just also showing up to something. If you showed up tonight in person or online, thank you. That's a one step in your advocacy journey with all of us here. And I would also suggest that you reach out to your legislators. So wherever you live, or even the legislators maybe that represent the area that the College of Medicine is in. They love to hear from students, and you certainly have a point of view. And many of the things that we talked about tonight will certainly be a part of your journey as a patient, an advocate, a physician, and a healthcare team partner.
Ms. Hoffman, before you pass on the mic, and I didn't share this with you prior to this evening's event, when I took a brief look at the RSVP, we've got a host of community members with us who are not associated with any university. We have students from Phoenix College's dental hygiene program. We have students from Creighton University from their medical program and a host of other programs. We have students here from the U of A. We have faculty, staff, and students from ASU and a whole host of other spaces. So the advice to the medical students, does that apply to the rest of them, or what else can all of those joining us tonight also do to help or make an impact?
Absolutely, it applies to everyone, and certainly my invitation to, again, I've built many relationships over the years, so I would love to hear from the students, and in the chat box for anyone viewing online, maybe we can ask them to email you, and then let's have a policy discussion. Let's do that. I'm happy to do that. And I know that we have many partners that can speak to that scientific research, clinical perspective too, but we're all in this together. And I can't tell you even pharmacists, the patients get to know their pharmacists and physicians so well, but let's be honest, that is not who is making most of the healthcare decisions. It's a payer, it's a PBM. They throttle and steer and, can I say hijack, patient care. That is the reality. So no matter what the education of our healthcare team members, ultimately, we kind of have an intervener. But once we stipulate that, then we have another conversation, and then we work together to build synergy and consensus and policy.
Thank you. And Dr. Shaibi, what would you like us to walk away with?
With some of the leftover food, there's a lot. Sorry, Michael. I'm a jokester, guys, and I apologize for, well, actually, I don't apologize for that. I'll speak from a scientific perspective, if you don't mind. Science is a way of thinking about understanding what we currently don't know. It is not the answer. It is an approach to really understanding things. And science evolves over time. The way we design studies, the way we carry these studies out, the way we analyze data. And it is just a pursuit of finding answers to questions that we don't quite know the answers to yet. And to piggyback off of what Julie says, it has to be emotional. We are all in this in a way that asks questions in different ways. And so be humble about the questions you're asking and who you're asking those questions with. Listening to different approaches. I've come to learn quite a bit, believe it or not, by just listening to really smart people, like the people who are on this panel and the community members and partners. But I sit and review grants all the time at the highest level and think, wow, I didn't know that. I had no clue. Is this worth X number of dollars? I don't have the answer to that. That's a question that I think is at the next level, but it's an important question, and this is an important way of asking and answering that question, but it's not the only way. Communities have solutions, and it's important that scientists understand that there's empowerment within communities, and we need to engage with those communities to really be able to ask the right questions and answer them in the most appropriate way, because the answers are not in the ivory white tower at all. And I think, you know, what's happening in the real world is this shift to either not believing in science as an approach or expecting that the universities and science is going to answer these questions, and neither of those are the truth. And so I think, well, neither of those are closer to the truth than our approach together to kind of trying to figure things out. So I don't know if that was an answer, but
it's a great perspective. Thank you. With the remaining time, I'd like to open up the floor to our participants. So if there are questions on the floor, let me know. I will come to you. Feel welcome to raise your hand or stand up. And I've got one question, and then Dr. Hartmark-Hill, if we could bring you back on screen if you've got any comments or questions to share from the audience.
Yes, I just want to really lift up all the comments that were made this evening. I so appreciate the discussion about bringing diverse groups together and building those coalitions. And I'll add that from experience, bringing people together and really well articulating common values makes legislators' job easier too. When their constituents can come to them and say, hey, this is for my kids. You know, maybe we had a different take on it at the beginning of the legislative session, but I now understand how this helps me and my family and my community. I think those types of messages are really important. And so to build those coalitions is really powerful. I've put in the chat diabetes.org/advocacy, just as one stellar example of an institution organization that's put together toolkits and really made this easy. I will take up the generous offer to have a policy session. We have done that many times in the past and would love to do so again. I do have some comments and questions in the chat that I want to bring forward. So Dr. Omar Escontrias says, great panel of speakers. Can you share with us a case example in which research has been used to influence or inform public policy related to diabetes in Arizona?
I can answer half. I'll leave the other half for you. Several years ago, we brought together a diverse group of people who work in science, research, policy, state agencies, patient advocacy organizations, and put forth a piece of legislation that is now statute, and every 2 years there is a diabetes action report that is mandated to be put together by the State Department of Health. Daniel has one under his belt so far, and we have already started working on the one that is due January of 2023. And so that comes out after an election. So the legislative terms are for 2 years. So when a new legislator and or governor, if it's that election cycle, is seated, as of January 1st, there's a new diabetes action plan. And I'll make sure that we do get that link back out to the people who have joined, because we know that data is really slow to follow. And so there's always a lag time. So if you just add some numbers to what's in that report, you can see the tremendous impact that diabetes has on this state. And I know that we have used Dr. Escontrias's research, and Dr. Shaibi sat on his PhD committee to inform that report and other policy. And we also have legislative support this next session for diabetes management and self-management and education for access patients, up to 10 hours at diagnosis, or if there's a change in diagnosis. And we were honored, and Daniel and I and Dr. Escontrias, State Department of Health, we were honored that Arizona was just selected by the National Association of Chronic Disease Directors and the CDC to be part of a program with a few other states to work to bring the National Diabetes Prevention Program to access our Medicaid provider. So those are just some of the things that have happened even during COVID, that we're just thrilled that have local research has prompted those incredible laws.
Thank you for that. I see we've got one question in the audience. I'm going to run up there, and then Dr. Hartmark-Hill, I'll turn it back over to you. Oh, no need to get up. If you just let us know your name so everyone online knows who you are, and feel welcome to ask your question.
Okay, thank you. Yes, hello everyone. My name is Karen Helsner. I am been a registered dietitian for the past 20 years and a health coach, and I'm an applicant to UACOM Phoenix this year. I didn't expect to get so emotional tonight. I'm over here choking up, because to be in a room of individuals who share this passion and the imperative work that you all do out there, like this is how we make a movement and an impact. And there's so many variables that come into play, and they have to be attacked from so many angles. If you don't mind me taking one more minute, currently I see it on both ends, because I'm in Banner Behavioral Hospital here in Scottsdale. So I see people at their darkest moments coming in with all of the mental instability and, substance abuse, and A1Cs are at 9, sometimes closer to 11. It's and nothing is managed, and what we manage there is we just try to manage their blood sugars that are in the 300s, but we don't have time with them, and so the impact just doesn't happen. If I can have a 5-minute conversation with somebody there, though, and it maybe makes something and the light bulb turn on, it's okay, that's a win. On the other end, and this may be a good group to get everybody involved with, I work for Anderson's Nutrition, and we're a group of consultant dietitians. I see people telehealth. We have offices here all over the Valley. I see people internationally. And I have an hour or an hour and a half with them. And that is the impact. Like and it's getting to that mental health where they are, the emotions are out and they're crying, and I've never met them before, but we're getting to the root of changing the behavior so that they're empowered to make the changes and to see them come off their medication or at least come down. That to me is like the ultimate. So whatever I can do to help in this, which is why I'm trying to get into medicine, because there's only so much I can do right now, but I just, I've seen the movement and we're getting there. Insurance now reimburses for our services, which has only happened in the last, I would say almost since COVID. And people don't realize, so maybe spreading the word that you can come see for diabetes unlimited and have that time and that continuity of care. So anyways, thank you. I could keep going.
Yep, thank you for sharing. I appreciate that. Any responses from the panel?
Well, I teach in the nutrition program, so yay, dietetics. Yeah, it's powerful. I forgot what I was going to say. Sorry.
I would just add that is one of the things that often hasn't been covered. And so similar to getting mental health services, if somebody has to pay out of pocket and they are, let's say, a student not on their parents' insurance plan, it almost, it is another barrier to care to say, okay, it's $150 for this, or it's $200 for that. And most people just won't pay that. And then you see the reimbursement side and you know that where you're paying a cash price of $150, maybe the provider is only being reimbursed, $42 or something like that. So that's another thing that those policy talks that we can all have very personalized together, where we have to really put a value on something like that. What is the value? Is it 150 or is it 42? Or is it somewhere in between to make bring the costs back down and not have healthcare at a manufactured suggested retail price? That's one thing I would mention about accessing those services.
I think it's Karen, right? Yeah, thank you for that comment, Karen, because I think one of the things that people don't necessarily equate diabetes to is the psychosocial comorbidity of depression, anxiety. I think it's not one causing the other, it's they're collinear. And so when we think about prevention of diabetes, particularly in high-risk kids, we don't just address their behaviors related to eating and physical activity. We address the social and emotional component, and our outcomes aren't just, we try and be sophisticated in our outcomes as they relate to diabetes. We try and be as sophisticated in our outcomes as they relate to social and emotional health. And I think if we don't think about those two conditions as collinear and comorbid, the prevention and treatment approaches for either won't be effective. And how do you marry those two things? And that's where I think the advocacy becomes important, is because in the primary care setting, you can manage medically diabetes pretty well, but without a CDE or someone who's able to connect with them on their emotional health or anxiety, depression, it doesn't matter how much metformin you give them or how much combination therapies you give them, you're not going to see improvements in their health. And so I don't think we need to think either or, we need to think both, and those medication management need to have strategies that address the social and emotional component to physical health as well. So thank you for that, Karen.
Dr. Hartmark-Hill, any comments from you, questions that are coming in?
I do have a comment from a participant, but I first want to just echo Dr. Shaibi's comment. As a family medicine physician, who's worked in multiple community-based, federally qualified healthcare centers where it is an integrated team-based care model. We know that's evidence-based, we know it affects outcomes, and we know that that can help deliver whole person care. So that's just something that we're very passionate about. Karen, your passion and compassion for people is very much in line with the students that we have here at the College of Medicine, Phoenix. So I'm very happy to hear that you're an applicant. I'm going to turn to a comment and question from Brenda Thompson, who is also very preventive medicine minded. She says, I am moved by the connections between research and public education and access to care. The stats are mind-boggling and a national health crisis socially and economically. But I'm also shocked by the demographic disparities. Those most affected have the least resources and lower level of care. How do we address this?
Yeah, all right, I'll take a stab. It was from Brenda, is that right? So Brenda, thank you for that comment. I think you're kind of addressing what we've coined the term, the social determinants of health as the root causes of health disparities and those factors that oftentimes are missed. In other words, where you live dictates your health more than what you do or the opportunities that you have. And so we're thinking about this in multiple ways in our group. When we're working with interventions, we're doing these in the community setting and we're considering those social determinants of health, such as access and education. And so in our diabetes prevention programs for kids, what do? We bring in education folks from ASU to talk about the importance of education early on in life. And it takes us a little bit, like these parents are like, well, yeah, we believe in education and want our kids to go on to college, but we say, no, this also helps them prevent diabetes. The more money you make and the more access you have to education, the less likely you're going to have diabetes. And it's not folks who are investigators who are coming in, it's folks who have actually lived it and done it, that lived experience. And so that's how we've integrated at least a little bit about the consideration of the social determinants of health. But ultimately, we're talking about those structural factors that need policies to change access to the decisions that we know are healthy. So I'll change that to my colleague, Ms. Hoffman, to talk about how we can address those policies.
Well, we need people from all of the diverse communities to join in our policy discussions. Policy is not a top-down. I can't stress enough the number of people who have suggested bills or just had a little issue or concern that became a bill, that became a law. I mean, dozens and dozens. That the legislators love to hear your stories and exactly what Brenda was talking about. The demographic information that's in our diabetes action report and that's routinely updated on the Access website on their membership enrollment demographics is shocking. And all of the demographic information is not even captured through the application and eligibility process. So we know, I want to say around, I can't remember if it's like 25 to 35% of people either didn't answer a certain question. So there's this entire group of uncaptured demographic information about patients. And that for all of us is a challenge too. I know that much of Dr. Shaibi's work is scalable. And I love that word and that process and that as a concept, because work and research that he's done can be easily adapted to specific communities or considerations we've come across. There are religious considerations when it comes to chronic disease management. And that crosses all colors, and just that there are variables that all of us keep in mind when we talk to communities.
Just briefly, I think about the importance of communication, and it has to be a back and forth between communities and the people that can try to do something about it. So if we have to know where they are so that we can help them where they are. And so we need to be listening and we need to be reaching out. We need to build trust with communities. Oftentimes they have been ignored for so long, they don't want to talk to you. They don't trust you. So the communication is just so key at so many levels to be able to help.
Thank you, Dr. Hartmark-Hill. Seeing that we are just at time, are there any last minute comments that you'd like to leave us with before I close us out?
Only to mention that the remaining comments in the chat are thank yous and words of appreciation and gratitude to all of you on the panel, which I will echo. So thank you. Thank you for the work you do.
Yes, and I will echo those comments, and my dear colleague, Dr. Hartmark-Hill, who's been instrumental in this journey to make Strips and Needles a Day in the Life possible, to make it happen, to bring all of the very many constituent stakeholders and sponsors and funding agencies, individuals, donors together to make this all possible. We do have some exciting news that I'll announce, is that, again, Dr. Hartmark-Hill has been instrumental in getting this exhibition to travel, and it will be heading to Tucson in a couple of months' time. We'll have additional, more robust and different programming that will reach a host of communities, rural, other hidden disabilities, including those of addiction, mental health, etc. And I'm looking forward to those opportunities. But for this evening, Dr. Sears, Ms. Hoffman, Dr. Shaibi, thank you for volunteering your time, for connecting with all of us here, for being so gracious to connect with me, and for the very important, powerful, and remarkable work that you do. So thank you to you. Thank you to those here in the audience with us this evening. And to all of you online, have a wonderful night.